Hello everyone. Let's continue to study Section 3, Cell Injury. The third type of cell injury is protein accumulation. Protein can accumulate in and out of cell. There are some causes of intracellular accumulation. Number 1, protein accumulation in proximal renal tubule. This is a picture from patient with proteinuria, which means excessive protein in the urine. We know some substances can be reabsorbed when urine passes through the renal tubules. The renal tubular epithelium reabsorb protein and form the tiny pink droplets in cytoplasm. Here, in the picture, this is a renal tubule, another renal tubule. In the cytoplasm, there are many tiny red droplets in it. The second one, excessive amounts of protein was synthesized. The plasma cells produce excessive immunoglobulin, which formed homogeneous eosinophilic inclusions in cytoplasm. There are those circles that black arrows point to. We call them Russell bodies, like this one, this one, this one. The third, defect in protein folding. When the intracellular transport of critical proteins is defective, the protein will accumulate in cytoplasm. For example, in alcoholic liver disease, the picture shows us red substances deposit in hepatocytes. They are here, here, and here. It's named Mallory body. In Alzheimer's disease, we also find protein inclusion aggregates. They are neurofibrillary tangles, consist of microtubule-associated proteins and neurofilaments. The fourth type, amyloid change. It means amyloid protein deposition in the extracellular space. The common sites of amyloid change are intracellular space, along the reticular fiber skeleton, and under basement membrane of small blood cells. This picture shows us the amyloid change of kidney. There are some homogeneous pink stuff in between the spaces of renal tubules. They are here, here, and here. It usually occurs in associated disease such as liver chronic inflammation, Alzheimer's disease, and malignant tumor such as medullary carcinoma of the thyroid and other diseases. In this picture of medullary carcinoma, there are many pink deposits in interstitial tissue, like here, here, and here. That's amyloid change. The fifth type, hyaline degeneration. Hyaline degeneration is an alteration in cells in the extracellular space and walls of arterioles, which gives a homogeneous glassy eosinophilic appearance. Hyaline degeneration in cell. Protein accumulations in cytoplasm is a kind of hyaline degeneration, such as Russell bodies, Mallory bodies, as we discussed before. Hyaline degeneration in connective tissue. It commonly occurs in dense oleaginous fibrous tissue, for example, old scars, glomerular fibrosis, fibrous plaque in AS. In this picture, the chronic splenic congestion may result in hyaline degeneration of its capsule. We magnify the capsule. You may notice the capsule is thickened in this area. It's gray-white, transparent, and glassy. That's the hyaline degeneration. Under microscope, the capsule consists of homogeneous pink bands. That's the hyaline of collagens. Hyaline change in walls of arterioles. Patients with hypertension and diabetes usually have hyaline change in walls of arterioles, especially in the kidney. This is a picture of spleen from a patient with hypertension. There are 3 central arteries in the middle. The wall becomes thickened, homogeneous red or pink, and the lumen of the vessel are narrowed. The 6th type of degeneration is pathologic pigment. It's abnormal deposition of pigment in cytoplasm and in extracellular space. It may be exogenous or endogenous. Most pigments are endogenous. Firstly, the hemosiderin. It is a hemoglobin-derived granular pigment that is golden yellow-brown and accumulate in the tissues. Mostly, hemosiderin deposition is pathologic. The red blood cells escaping from the blood vessels are absorbed by macrophages and then degraded by their lysozymes, so that the ferric iron from the hemoglobin combines with proteins to form ferritin particles. These particles aggregate and exhibit golden yellow-brown appearance, just like this picture. This is a lung from patient with left heart failure. We know left heart failure will cause chronic lung congestion. In the pulmonary alveoli, here, the pulmonary alveoli, hemosiderin aggregates in the cytoplasm of phagocytes. They are golden brown, like here. That's the macrophage. The macrophage. Many hemosiderin in the cytoplasm. So we call this macrophage as heart failure cell. In our body, small amount of hemosiderin is normal in the mononuclear phagocytes of the bone marrow, spleen, and liver, because there is extensive red cell breakdown. The iron can be identified by Prussian blue histochemical stain. In this picture, iron particles are stained blue, like here. Lipofuscin, we talked about it in cellular adaptation. When certain cells undergo atrophy, there will be lipofuscin deposit in the perinucleosome, just like here, and here. Tiny brown granules. It appears in hepatocyte myocardial cells or nerve cells with aging or with severe malnutrition. The lipofuscin is yellow-brown fine granules. In normal situation, it can be found in testis stromal cell or nerve cell. Essentially, lipofuscin is insoluble residue in autophagy lysozymes, which is formed by undigested organelle fragments. The third type of pigment is melanin. It is an endogenous brown to black pigment synthesized by melanocytes. In our skin, it usually locates in epidermic or mucosal basal layer. Look at this skin section. The melanin is here. Melanin could be local, for example, in nevus or melanoma. Melanin can also be systemic, for example, in Addison disease. The malfunction of adrenal gland cause increased synthesis of melanin. Patient with prostate carcinoma treated by large amount of estrogen also acquired darker skin because of increased synthesis of melanin. This is a picture of intradermal nevus. Here are the melanin. Some pathologic pigment is exogenous. For example, carbon coal dust in the lung. Tattoo is a form of localized exogenous pigment of the skin. The seventh type of degeneration is pathologic calcification. It is abnormal deposition of calcium salt within the tissue except for bone and teeth. Grossly, they are great white, granular or massive, solid, gritty deposits in tissue. Under microscope, it's blue, amorphous granular or clumped stuff, like here and here. The pathologic calcification has two types. Number one, dystrophic calcification. That means local abnormal deposition of calcium salt in the areas of necrosis. For example, in the foci of AS plaque, thrombus, necrotic bodies of parasites. This is dystrophic calcification in focus of silicosis. It's in the blue area. In aortic atherosclerosis, the atheroma has deposits of calcium salt. These scattering blue spots, like here, they are calcification. The second type is metastatic calcification. It means calcium salt deposition in some tissues caused by disturbance in calcium metabolism. It usually occurs in pulmonary alveolar wall, renal tubule basal membrane, and gastric mucosa. The cause of metastatic calcification includes increased secretion of parathyroid hormone. We know that parathyroid secrete calcitonin, which could reduce blood calcium and promote calcium deposition. The vitamin D related disorder and destruction of bone tissue caused by bone marrow tumor or skeletal metastasis. The renal failure could cause secondary hyperparathyroidism, which means high level of calcitonin. Under microscope, pathologic calcification has blue, granular, or clumped appearance. Some of them have concentric structure, like this one. Okay, let's take a summary. We talked about the different types of degeneration, including hydropic degeneration, fatty change, protein deposition, amyloid change, hyaline degeneration, pathologic pigment, and pathologic calcification. Here are some questions for you. Okay, this is the end of section